So I think the most of the things have been said. The association between fatty liver and non-communicable diseases like diabetes, hypertension, dyslipidemia, cardiovascular disease, CKD, and even malignancies have been spoken about. What I'll do is maybe next 15 minutes or so, I'll just show you some evidence that how is fatty liver or NAFLD associated with these non-communicable diseases, especially as I said, the metabolic risk factors, the cardiovascular, CKD. So I'll show you some evidence or some data or studies on this. I think by now, I think I'm pretty sure that you have all understood that fatty liver disease is part and parcel of a multisystemic disease, uh, part and parcel of metabolic syndrome, and some people take it as even a hepatic manifestation of metabolic syndrome, which means that if you have metabolic risk factors, you can have involvement of heart, you can have involvement of kidneys, arteries. So similarly, your liver can get involved, and that's known as, as I said, the hepatic manifestation of metabolic syndrome. So if you look at here, I think a lot of extra-hepatic diseases, predominantly, these metabolic diseases have been associated with the NAFLD. So what, as I said, I'll show you today some evidence about the association of NAFLD predominantly with metabolic risk factors, which I said have been spoken about, but I'm going to show you some studies on this. Also show you some data on the cardiovascular link, CKD link, and also maybe some malignancies, that how is fatty liver disease related to all these metabolic risk factors. The first and the foremost thing what we need to understand, which again partly has been covered, is that no doubt that metabolic syndrome and fatty liver disease are very closely associated. But the other thing what we need to remember is that there's something called as bidirectional link between fatty liver disease and metabolic syndrome. So what do you mean by bidirectional link? So this bidirectional link means that if you have any metabolic risk factor, say diabetes or obesity or full-blown metabolic syndrome, which means by the criteria, say ATP3 criteria, we call it as 3 or more components. If you're there, you call it as metabolic syndrome. So if you have metabolic risk factors or full-blown MS, it puts you at a risk of having fatty liver disease. That is the one link. The second is some patients, when they start, they just have fat in the liver. Start with fatty liver, but there are no metabolic risk factors, no obesity, no diabetes, no hypertension, no dyslipidemia, just fatty liver. Small fraction, but it can happen. But then there is data available which has shown that on long term, these patients, those who start with fatty liver, tend to develop metabolic syndrome and metabolic risk factors. So this is the other link. So both ways, MS leading on to fatty liver and fatty liver leading on to MS, and this is known as the bidirectional link. How this happens, again, I'll show you some data on this. And another thing what we need to understand is that when we talk about the link between metabolic risk factors and fatty liver disease, there's no doubt they are associated. The other thing is that the metabolic risk factors also determine the severity of fatty liver disease. All fatty liver disease are not same. You can have just fat in the liver, which is known as NAFL or non-alcoholic fatty liver, or earlier we used to call it as simple steatosis. Some patients you heard can have inflammation and fibrosis, which is known as NASH. They can progress on to cirrhosis, liver cancer. So what determines this severity? That who's going to have only NAFL? Who's going to have only NASH? Or who's going to have cirrhosis or this thing? So there are many determinants of this severity, but one of the major determinant is again the presence of metabolic risk factors or the metabolic syndrome. So again, I'll show you some data on this. Finally, I'll show you some data, as I said, link between the cardiovascular disease, CKD, malignancies, and fatty liver disease. Okay, so let me start with, that what is the evidence to say that yes, fatty liver disease and metabolic syndrome are, associated. Large number of studies are there to show that link. I've just picked up this one large study of around 3,000, participants. Around 1/3 of them had fatty liver. So then they looked at what are the risk factors for fatty liver in these individuals. So what they found was that all the metabolic risk factors, and if you look at the odds ratio here, if you are centrally obese, which is measured by so-called waist circumference, if you're centrally obese, you are at a 5 times the risk of having fatty liver disease in comparison to a person who is not centrally obese. Similarly, if you are a diabetic or even you have just hyperglycemia of a sugar more than 100, it puts you at a 2 times risk of having fatty liver disease. Same is true for hypertension and triglycerides. So these are the various kinds of, various studies are available of these kind, which tells you, yes, that they are, associated. This is our own data. A large number of blood donors we had screened in PGI Chandigarh. And to our surprise, I think 53% of them had fatty liver disease, NAFLD, alcohol we had excluded, on ultrasound. And when we looked at again the predictors, we found it was the BMI, which tells you about the overweight obesity, waist circumference, which is the central obesity, your blood pressure, cholesterol, and metabolic syndrome. They were all, independent predictors of NAFLD. So I think this tells us that yes, they are, kind of related. Now let me show you some data that what is the prevalence of NAFLD in patients with, metabolic risk factors or metabolic syndrome. So again, I have picked up this very large, meta-analysis of around 80 studies done across, 20 countries, and around 50,000 patients with type 2 diabetes they had taken. We know that the global prevalence of fatty liver disease is close to around, 25 to 30%. But when they looked at the diabetics, this is, as I said, 50,000, patients with type 2 diabetes, the prevalence of fatty liver was 55%. And as the number of, components of metabolic syndrome go up, which means if you have diabetes, along with that, if you have obesity, or if you have hypertension or dyslipidemia, the figures can be as high as 80 to 90%, which means somebody who has a full-blown metabolic syndrome can have, fatty liver disease can be, 70 to 80% of them would have, fatty liver disease. Now, this is one Indian study which I picked up from Chennai, Dr. V. Mohan's group. Again, they, looked at these 500, odd patients. Around 1/3 of them had fatty liver. But when they divided them into, those with diabetes and without diabetes, look at the difference. Diabetics, again, 55% of them had fatty liver disease. And those without diabetes, normal glucose tolerance, 22%. Again, telling you that the NAFLD is obviously highly prevalent in those with metabolic risk factors and those with metabolic syndrome. Now, suppose you have, patients with, metabolic fatty liver disease. And as I said, there are, no metabolic risk factors. So they had taken this, without NAFLD patients and only metabolic risk factors, but no NAFLD here. So over a period of time, they saw that around 25% of them, they developed, fatty liver disease. So now what were the determinants of, fatty liver disease over a period of time in these patients with, metabolic risk factors? I think, again, the hazard or the risk of, having fatty liver disease, even if you don't have in the beginning, you just have, say, metabolic syndrome or metabolic risk factor, over the years, right, your risk of having fatty liver disease goes up. And this goes up, as I said, with the number of components of metabolic syndrome you have. If you have only one component, maybe 2 times the risk. If you have 2 components, 3 times the risk. If you have 3 components, maybe 4 times the risk. So as the components of metabolic syndrome keep increasing, your risk of developing fatty liver disease goes up. The other angle could be to show you some data on that. How about those that today, if you look at all patients with fatty liver disease, NAFLD, as I said, is a huge pandemic. 25 to 30% of general population would have it, right? And the patients visiting our liver clinic or say to the general medicine OPD, I think a lot of them would have fatty liver, which is incidental detected. So now if you look at metabolic syndrome or metabolic risk factors in them, what is the, their prevalence. So I think this is again our own data. We have a consortium in India called the Indian Consortium of Non-Alcoholic Fatty Liver Disease. This is known as an ICON-D, and around 40 centers all over the country are participating and contributing data in this consortium. And this was our interim analysis, which we had done last year, and we presented this year in the Basel meeting of around 4,000 patients. So again, to tell you that out of this, I think when we looked at the various, metabolic risk factors, I think one metabolic risk factors, at least one metabolic risk factor was present in around 93%. And when we looked at the full-blown metabolic syndrome, which means 3 or more components, it was present in 43%. And the most common, metabolic risk factor was the central obesity, which was measured by, waist circumference, which was present in around 83% of these patients. Now, suppose, as I said, the other way to tell you about the bidirectional link, that you have a patient who starts with, say, fatty liver, doesn't have, metabolic risk factors. So is he or she at a higher risk of developing metabolic risk factors on a long term? So I'll show you maybe some data on this. And this is again a very large study, long-term study of mean follow-up of around 13 years, biopsy proven patients with, NAFLD with elevated ALT. So what they saw was that when they started with fatty liver in these patients, only around 8-9% of them, they had diabetes mellitus. But after 13 years of follow-up, if you look at this, 78% of patients had developed either diabetes or impaired, glucose tolerance, which tells you that even if you start with just fat in the liver, and over a period of time, you are at a higher risk of developing diabetes, which Professor Sareen said that diabetes is now thought to be a liver disease rather than a pancreatic disease. And why this happens, I think he did say about the hepatic insulin resistance, and I'll show you some data on this. So there are a large number of studies like this. I've just put this table here where people have looked at that the patient started with fatty liver and over a period of time, they developed, type 2 diabetes. Similar kind of data is available that people started with fatty liver and over a period of time, they developed hypertension. And this is one, large meta-analysis which I have picked up of around 20 studies and around, a population of around 117,000 and a median follow-up of around, 5 years. So what they found was that the NAFLD no doubt was associated with type 2 diabetes. But when they looked at these around 8 studies and around 81,000 patients with NAFLD over a median follow-up of maybe 5 years up to 11 years, NAFLD was associated with increased risk of metabolic syndrome 2 times. So which means that if you today, start with, just fat in the liver, and I think after 5-10 years, your risk of having diabetes, your risk of having metabolic syndrome goes up maybe by 2 times in comparison to somebody who does not have fatty liver disease. I think that's a very important information. The third thing which I told you was that the fatty liver disease and metabolic syndrome, that if you have metabolic risk factors, your severity of fatty liver disease goes up. Severity means NASH. NASH is a severe form of fatty liver disease. NASH with fibrosis is a severe form of fatty liver disease. Then they can go into cirrhosis, liver cancer. So the same meta-analysis which I quoted earlier, when they looked at the presence of, NASH, it was 37% and advanced fibrosis was 17%. This was amongst diabetics. So these figures are, way ahead of, the general population or the people, those who do not have diabetes or those who do not have metabolic, syndrome. So I think, as I said, your severity goes up. And I think there are again large number of studies which have shown that over a period of time, what determines that which patient is going to progress with, increasing hepatic fibrosis, which patient is going to progress to cirrhosis is determined by lots of factors. But as I said, metabolic risk factors are very important. If you look at here, diabetes, obesity, LDL, insulin resistance, hypertension, diabetes, I think all these are, responsible for, causing progression in these patients. And this is again one study from US, Baylor School of Medicine, which again looked at the effect of these metabolic risk factors on development of cirrhosis and liver cancer in patients with NAFLD. And look at here, if somebody has diabetes, obesity, hypertension, and dyslipidemia, which means, full-blown metabolic syndrome, then your risk of HCC is around 6 to 7 times higher. Similarly, your risk of having cirrhosis is around 2 to 3 times higher. So I think this, as I said, metabolic risk factors would determine, the severity of disease. Finally, I think this was actually shown to you that how, this bidirectional link, comes in. We know that how fat occurs in the liver, or how the fatty liver disease occurs. I think you heard earlier that basically it is because of we said about the metabolic risk factors and all, but basically there are three sources of, fat to the liver. Important one is that if you have, insulin resistance at the adipose tissue level, and if you have somebody who is adipose tissue is inflamed and is enlarged, and there's insulin resistance at the adipose tissue level, that increases the delivery of free fatty acids to the liver, which is known as increased lipolysis. So that is the major source. And second is some de novo lipogenesis happens in the liver. And third is your diet, which is a not very important source, but one of the important sources. I think that these three contribute to the fat in the liver. So once you have fat in the liver because of these sources, then what happens is, because of the molecular mechanisms within the liver which affect the insulin signaling pathways, there occurs the hepatic insulin resistance, or the insulin resistance occurs at the hepatic level. So the normal function of the insulin is to keep the inhibit the glucose production in the liver, right? So that's the normal function of the insulin. So once you have hepatic insulin resistance, the insulin is not able to inhibit the production by the liver. So there's a impaired, insulin inhibition of glucose production. So there's increased glucose production, which comes in the circulation, causes hyperglycemia, which causes, increased secretion of insulin, leads on to hyperinsulinemia. So, the pancreas will function more, and a time will come when pancreas will get exhausted and the patient will develop diabetes. And because of, this hyperinsulinemia, hyperglycemia, other than, diabetes, your endothelial vascular dysfunction, starts happening, your dyslipidemia starts happening, your coagulation profile gets disturbed. So you tend to, at a higher risk of, having cardiovascular disease, chronic kidney disease, and various other things. Lastly, I think this is again being spoken about, the relationship between the cardiovascular disease and the CKD and the malignancies. Maybe I'll just briefly tell you some data that cardiovascular disease is, is the main cause, or the most important, or the most common cause of death in patients with NAFLD or NASH. It's not the liver disease. It's the cardiovascular disease, which is the most common cause of death in patients with NASH. Second is malignancy, and third is the liver related. So cardiovascular disease are again two types which have been shown in patients with fatty liver disease. One is the anatomical diseases, that you can have increased, subclinical atherosclerosis. You can have increased coronary artery calcium. You can have, arterial stiffness, aortic wall, sclerosis, and the deposition of fat in the myocardium and in the epicardium, which will, affect the myocardial metabolism, leading on to cardiac arrhythmias, and leading on to, LV diastolic and systolic, dysfunction. So based on this, as I said, again, there are a large number of studies. Time doesn't permit me to get into the details, but I'll just picked up this one, meta-analysis, recent meta-analysis, again of around, 42,000, subjects, 16,000 of them having fatty liver disease. And what they looked was the coronary artery calcium. And they found that the patients with NAFLD, when they compared it without NAFLD, I think the patients with NAFLD were at a higher risk, maybe 1.6 or 2 times higher risk of, having the coronary artery calcium, which is, could be taken as a marker of, subclinical atherosclerosis in these patients. Again, there are studies on the carotid intima media thickness where people have looked into, again have shown that these patients are at a higher risk of having subclinical atherosclerosis. Again, this meta-analysis looked at the fatal and the non-fatal cardiovascular events in patients with fatty liver, and both were found to be higher in patients with NAFLD. Similar meta-analysis is available for chronic kidney disease and NAFLD in general, and NASH, which I said is a severe form of fatty liver and advanced fibrosis. They were at a 3 to 5 times higher risk of developing chronic kidney disease in comparison to those who did not have NAFLD. This is again our own work where we had looked at chronic kidney disease in our patients with fatty liver disease, and we looked at the macroscopic and microscopic proteinuria in them, calculated their GFRs, and we found that 1/3 of them had impaired renal function. And when we looked at the risk factors, I think other than the metabolic risk factors, the severity of liver disease, which was seen by as I said, you heard about the transient elastography or fibroscan, where we look at the hepatic fibrosis and the raised ALT, where they were independent predictors of impaired renal function. Let me summarize now by saying that yes, liver cancer, you heard, obviously goes up in these patients, and again this we had shown that NASH as a cause of liver cancer is going up. But then other than the liver cancer, the NAFLD is also associated with lots of other extra-hepatic malignancies, and this particular study had shown that in males, patients would be at maybe twice the risk of having colorectal CA, and females again twice the risk of having breast cancer if they had NAFLD. So, ladies and gentlemen, let me summarize what I said in the last 15-20 minutes is that NAFLD is associated with lots of extrahepatic diseases, but the predominant of them are the non-communicable diseases, and that is the reason the Ministry of Health and Family Welfare has integrated this into their national program of NCPCTS. And I showed you that there is a bidirectional link between patients with NAFLD and metabolic syndrome. And what is this bidirectional link? Bidirectional link means that there is increased risk of NAFLD in patients, those who have metabolic syndrome or its individual components like diabetes, hypertension, and dyslipidemia. But even if you start with just fat in the liver, no metabolic dysfunction, over a long term, you are at a higher risk of developing diabetes, hypertension, and metabolic syndrome. So that's the bidirectional link. I also showed you data that metabolic syndrome in patients with fatty liver disease increases the severity of fatty liver disease, more of NASH, more of fibrosis, more of cirrhosis, more of liver cancer in those who have metabolic risk factors. The pathogenesis I showed you at the insulin resistance, which is happening at various levels. And then finally, I showed you about the relationship of, the NAFLD with, cardiovascular disease and the cardiovascular events, chronic kidney disease and hepatic, and the extrahepatic malignancies, which increases in these patients. All this, has a bearing in the management of these patients. Again, the time doesn't permit me to get into those details, but I think we can have discussion about the bearing of all these in the management of, these patients. So thank you very much for your kind attention, and I'll be happy to take any questions. I'll stop sharing my screen here. Thank you.